Good morning, good afternoon, and good evening. My name is Gabby Escudero, and I'm the Deputy Director of the Data for Impact Project. Welcome to all of you. This is our fifth and final webinar in our series focused on health equity in global health monitoring, evaluation, and learning. Today's presenters will discuss findings from the first nationally representative survey focused on adolescents in Bangladesh. I'm going to go ahead and switch off my video right now, but I wanted to first properly welcome all of you. We want to save on bandwidth since we have so many people joining from very many locations. So next slide, please. For those who may be unfamiliar with the Data for Impact Project, or D4I, it is funded by the United States Agency for International Development. D4I is a consortium led by the University of North Carolina at Chapel Hill in partnership with Palladium, ICF, John Snow Incorporated, and Tulane University. D4I strengthens local capacity to generate and use high-quality health data for strategic decisions on health policy and programming at national, subnational, and community levels. D4I investigates program effectiveness, integrates gender into all activities, supports adaptive management, and learns from evidence. D4I draws on the technical expertise that exists in each partner organization and an extensive network of local partners in USAID priority countries. You can see here the 6 different areas that Data for Impact works in. D4I generates evidence, strengthens capacity through fostering collaboration, experimental learning, mentoring, peer networks tailored to partners' needs, and ensures data quality. We also work on integrating gender throughout the project and promote data usage and learning. As I mentioned, this is the 5th and final webinar in our series focused on health equity and global health monitoring, evaluation, and learning. Health equity is achieved when everyone has a fair opportunity to live the healthiest life possible. Monitoring, evaluation, and learning plays a critical role in fostering equitable global health programs and policies. High-quality data can help stakeholders better understand current health inequities, promote equity-sensitive program approaches, measure progress towards equity, support accountability for equity, and raise awareness about actions that affect health equity. USAID's inclusive development approach champions health equity with the idea that every individual and community of all diverse identities and experiences play a pivotal role in the transformation of their own societies. USAID works to integrate inclusive development in the areas of disability rights, inclusion and equity, mental health, and youth, among others. Next slide, please. Today's webinar will be presented in English with closed captioning available. If you'd like to turn on English closed captioning, select the Live Transcript CC button from your Zoom menu. If you wish to hide the captions later, please select the same icon again and select Hide Subtitle from the menu that appears. These captions are generated by an automatic feature in Zoom, therefore they may not be 100% accurate. Lastly, we are recording this webinar and we'll be sharing it in an email following the webinar along with the slides. Next slide, please. Today's webinar will delve into crucial topics affecting Bangladeshi adolescents, including on preferred age of marriage, attitudes towards gender norms, depression, and experience with intimate partner physical violence. The presenters will share evidence of these topics and illustrate how these subjects intersect with USAID's inclusive development approach. At the end of the presentations, there will be time for questions, so please write any questions you have in the Q&A box, which is at the bottom of your screen. Next slide, please. The first presenter today is Dr. Sean Curtis, who will begin by providing an overview of the Bangladesh Adolescent Health and Wellbeing Survey. Dr. Curtis is a professor in the Department of Maternal and Child Health at the Gilling School of Global Public Health, University of North Carolina, and is the faculty principal investigator for the D4I project. She has over 30 years of experience in monitoring and evaluation of population, health, and food security programs, and in reproductive health and survey research. She has been working with the Measure Evaluation and the D4I team in Bangladesh since 2012. Over to you, Sean.
Thank you, Gabby. And so, as Gabby said, I'm going to provide a very brief overview of the survey design and methods. Next. Okay, so why did we do the adolescent health survey in Bangladesh? Well, in Bangladesh, adolescents aged 10 to 19 constitute over 1/5 of the total population. In 2018, the Ministry of Health and Family Welfare developed a national strategy for adolescent health through 2030. The survey was initiated to gain a better understanding of the state of adolescent health and well-being and the needs of this population to inform implementation of this strategy. Next slide. So several organizations were involved in the survey. Survey implementation was led by the government of Bangladesh through the National Institute for Population Research and Training. Technical assistance was provided by USAID, Data for Impact, and ICDDRB. Data collection was conducted by Human Development Research Center, and financial assistance was provided by USAID, the government of Bangladesh, and UKAID. Next. So the objective of the survey was to examine and understand the state of health and well-being for adolescents aged 15 to 19. Younger adolescents aged 10 to 14 were not included due to the sensitive nature of some of the survey questions and issues in obtaining ethics approval for younger youths. The survey is a nationally representative sample survey of around 20,000 adolescents, and the survey is designed to provide representative estimates for ever married girls, and unmarried boys at the national level, for urban and rural areas, and for 3 regions in Western, Central, and Eastern. Data collection was conducted from July 2019 to January 2020 and was done by 18 teams. I think the slides are getting a little ahead. Could you go back, Moy? Thank you. Okay, go to sample selection. Okay, so we have a survey sample was a multi-stage sample. Next, so we selected 72,800 households from 736 clusters. Within these households, next, we selected 5,066 ever married females, 8,284 unmarried females, and 6,538 unmarried males. Next. Okay, and next. The response rates for the survey were high. We were able to interview 67,093 of the 72,800 households selected for a response rate of 98%. Next. For married females, we were able to interview 97% of the selected respondents. Next. For unmarried females, we were able to interview 94% of the selected respondents. Next. And for unmarried males, the response rate was 85%. Next. The survey covered a range of topics as shown here. In this webinar, we will be highlighting analysis of some of the data collected on marriage, gender norms, mental health, and on violence and harassment. But there is a lot of other content as well. So I'll now hand over to Nahid. Thank you.
Thanks, Sean. So our next presenter is Dr. Nahid Kamal, PhD, who will present on the preferred age of marriage among female adolescents in Bangladesh. Dr. Kamal is an independent consultant with over 20 years of research and evaluation experience in population, health, nutrition, and WASH. Dr. Kamal's past professional affiliations were with the Population Council, the Global Fund, Marie Stopes International, and the Measure Evaluation Project. Over to you, Nahid.
Thank you, Gabby. The first presentation today looks at adolescent girls' preference on the timing of their marriage. And I'm presenting the findings on behalf of the team that worked on the analysis. Next slide, please. In the Bangladeshi context, normally it is the parents and guardians of girls who take marriage-related decisions such as choice of groom and timing. Girls themselves are known to have little agency over their marriage decisions. The objective of this study was to assess adolescent girls' preference on the timing of their marriage using the Bangladesh Adolescent Health and Wellbeing Survey, where we had asked ever and never married girls of ages 15 and 19 their preferred age at marriage if they could decide the timing of their own marriage. Next slide, please. Here is a brief background on early marriage in the country. Bangladesh ranks among the top 5 countries globally with the highest levels of early and child marriage, when the practice is known to be detrimental to a girl's overall well-being. Just to provide some perspective, 50% of Bangladeshi girls aged 20 to 24 are married before age 18, compared with 37% in Nepal, 23% in India, and 18% in Pakistan. While the legal age for marriage is 18 for girls in Bangladesh, the median age at first marriage among women aged 20 to 49 has increased rather slowly from 14 to 16 years during the last 3 decades, according to demographic and health surveys. This is an unfortunate paradox given the various government and NGO-led initiatives that have been in place since the early 1990s to prevent early marriage, such as the National Female Secondary School Stipend Program. And progress to prevent child and early marriage has been slow, and recent research reports point out that efforts must be accelerated significantly in order to meet the Sustainable Development Goal and the national target by 2030 and 2041, respectively. Next, please. The marriage module in the survey questionnaire was administered to 4926 ever-married girls and 3943 never-married girls between the ages of 15 and 19. Our findings are based on descriptive statistics and bivariate analysis. Additionally, the multivariate linear probability model was used to identify the factors associated with adolescent girls' preference on timing of marriage. Next slide, please. In this survey, we found that almost 39% of the girls of ages 15 to 19 were married. Among these married girls, 87% reported that they were married before age 18 and 46% before age 16. 1/4 of the girls currently age 16 were married, compared with 2/3 of girls currently age 19. Thus, the older the girl, the more likely she is to be married, as expected. We also found some distinct patterns. For example, relatively higher proportions of adolescent girls are married in rural areas, 42% compared to 31% in urban, and in the western divisions of the country, 49% in Rajshahi compared with 18% in Sylhet. Next. Next, we looked at the level of educational attainment among married and unmarried adolescent girls and found the age-adjusted levels to be lower for married girls. To keep things simple, I'm presenting 2 age groups here: unmarried and married 16-year-olds on the left, and married and married 19-year-olds on the right. We have 3 categories of education here: no or primary, represented by dark green; secondary incomplete, represented by orange; and finally, secondary complete or higher, represented by light green. Among the 16-year-olds, secondary complete or higher is 23% among unmarried girls, compared with 12% among married girls. Similarly, secondary or higher education was completed by 67% of unmarried 19-year-olds, compared with 30% of married 19-year-olds. And early marriage can be the cause as well as the consequence of dropping out of school, as indicated by available literature. Next. For constructing the variable of interest, preferred age at marriage, different questionnaires were administered to adolescent girls based on their marital status in order to account for differences in their circumstances. The never married girls were asked about their preferred age at marriage, and they were also asked if they knew at what age their parents would like them to be married. And we found that the majority of the adolescent girls' preferred age at marriage was the same as their parents' preferred age. On the other hand, the ever married girls were asked whether they felt that they were married at the right age or would have preferred to marry earlier or later. Among those who responded that they would have preferred to be married at a later age than they did, their preferred age was asked. Next. What was striking is that only 31% of the ever married girls in the survey felt that they got married at the right age. The majority, 65%, would have preferred to marry at a later age than they did. Next. This figure shows the difference in preferred age at marriage between married and unmarried adolescent girls. We had assumed that 21 years is typically the age when an average Bangladeshi girl may be expected to complete her bachelor's degree, and hence our choice of categories in the horizontal axis. Those who prefer to marry before age 18, between ages 18 and 21, and after age 21. It is seen that there is little support for marriage before age 18 by both groups, 24% among married and 1% among unmarried girls. The majority from both married and unmarried groups prefer to marry between 18 and 21 years, 68%, 52% respectively. However, 8% of currently married adolescent girls and almost half, 47% of unmarried adolescent girls reported a preference for marriage after age 21, which, as I mentioned earlier, is the age when an average Bangladeshi girl completes her bachelor's degree. Next. What was interesting about these 47% girls who want to marry after age 21 is that among the girls whose parents' preferred age of marriage was lower than theirs, 75% thought that it was quite likely that they could negotiate the timing of marriage with their parents with the help of siblings and relatives. Next. Now we present findings from the multivariate linear probability model showing the distribution of unmarried adolescent girls who would prefer to marry after age 21 by various individual, contextual, and societal level factors. I shall go over the variables that were statistically significant and are signified by the orange boxes. For the first variable, current age, it is seen that a higher proportion of 18 to 19-year-olds, 61%, reported a preference to marry after age 21 compared to 15 and 16-year-olds. Then, if we look at the next significant variable, current schooling, it is seen that 55% of those currently in school wish to delay marriage compared with 23% of school dropouts and 28% in madrasas, which are schools following the Islamic curriculum. It is seen that girls who watch TV more have access to the internet or are members of youth clubs. In other words, girls with greater exposure to the outside world prefer later marriage. Girls with more egalitarian attitudes towards gender roles in socioeconomic participation and in marriage are more likely to prefer later marriage. And my colleagues will talk more on how these variables on egalitarian views were constructed in the later presentations. Living with both parents or one parent matters. Girls who live with both parents are more likely to prefer marriage after age 21. As expected, girls from higher wealth quintiles are more likely to want to delay marriage. 60% of the girls in the two highest wealth quintiles would prefer to marry after 21, compared with 35% in the two lowest quintiles. More girls in urban areas and in the eastern districts prefer delayed marriage. Finally, we looked at community effect and found that girls living in communities where less than 25% of adolescent girls are married are more likely to want to delay marriage. In other words, social pressure is a factor perpetuating early marriage. Next slide, please. Here is a summary of the main findings I have presented. The salient finding is that although the legal age of marriage for girls is 18, large numbers of girls are still getting married before this legal minimum age, and the vast majority of the girls getting married early, 65% in our sample of ever married girls, would have preferred to marry later than they did. Educational attainment is lower among married adolescent girls. Almost half of the unmarried girls in the survey, or 47%, reported a preference to delay marriage to 21 years or later, which is typically the age when they complete a bachelor's degree. The factors associated with a preference for marriage after age 21 include staying in school, belonging to higher wealth quintiles, living in urban areas, and finally, social pressure. That is, girls living in communities where early marriage is common are less likely to want to delay marriage. Next, please. Based on our analysis and a review of relevant literature, here are some recommendations to prevent early marriage. Increase investments to keep girls in school and make 12 years of schooling mandatory for girls. The UN recommends 12 years of schooling as basic education. In the National Secondary School Stipend Program, girls need to stay unmarried till age 16, which should be revised up to 18, if not more. It is also important to improve access to employment for girls at all skill levels. Secondly, targeted efforts are needed for subgroups such as girls in the lower wealth quintiles, those who are out of school, girls living in rural areas, and in the western districts, in order to increase their educational opportunities and aspirations for delayed marriage. Third, If girls wish to delay marriage, they need to be empowered to do so through laws and interventions that address their social and structural needs. Also, engage extended families to lend a voice to adolescents to negotiate the timing of their marriage, as many of the unmarried adolescent girls in the survey reported that they could potentially convince their parents to delay marriage with the support of relatives. Finally, future efforts to prevent early marriage might benefit from taking a more human rights-based approach. Our progress to prevent child marriage has been slow so far. It is time to rethink and recalibrate our efforts. That's all from me. Thank you.
Thank you, Nahid. Our next presenter is Dr. Kanta Jamil, PhD, who will present on factors that shape attitudes on gender roles among adolescents in Bangladesh. Dr. Jamil is a demographer by training, currently working as an independent consultant with over 35 years of research and evaluation experience in population, health, and nutrition. Dr. Jamil's past professional affiliations were with the IAP Worldwide Services, USAID Bangladesh, and the Johns Hopkins University. Over to you, Kanta.
Thank you, Gabby. Our paper, What Shapes Attitudes on Gender Roles Among Adolescents in Bangladesh, has been a team effort. I'm presenting the findings on behalf of the team. Next. In Bangladesh, substantial gender differentials exist in all outcomes and in all spheres of life, in various types of socioeconomic participation, political engagements, health status, access to care, property rights, etc. These various gendered inequalities mostly stem from Bangladesh society's conservative gender norms and attitudes. Adolescence is a period of social and emotional learning, and it is a crucial time for forming and shaping gender norms and attitudes. In our paper, we assessed the extent to which Bangladeshi unmarried adolescents hold egalitarian attitudes towards gender roles. We particularly focused on attitudes on gender roles related to socioeconomic participation. We also examined the factors that may influence and shape adolescents' attitudes on gender norms. Next. We collected information from 13,000 unmarried girls and boys aged 15 to 19. We asked whether they agreed or disagreed with each of the 4 statements. The statements were, a son should have more education than a daughter. Outdoor games are only for boys. Household chores are for women only. Women should not be allowed to work outside. A respondent was considered to have egalitarian attitude on gender roles when he or she disagreed with all the 4 statements. Next. Our result shows that unmarried boys and girls differ hugely in their views on gender roles. Girls were much more egalitarian than boys, 58% versus 19%. Next. We looked at the factors that may influence adolescents' egalitarian attitude on gender roles. We considered 3 broad categories: individual or contextual factors, peer influence, and social connectivity. Under contextual factors, we considered 4 variables: educational attainment of the adolescents, their household economic status, their place, and region of residence. Under the category of peer influence, we consider 2 variables that represent peer influence within the household and within the community. We shall discuss these a bit later. We considered 4 variables under social connectivity. They are whether respondent watches TV at least once a week, accesses internet at least once a week, whether he or she is a member of a social organization like sports club, book clubs, music club, boys or girls scouts, etc. We also looked at whether the respondent had participated in any adolescent program in the 3 years preceding the survey. Next. Peer influence. Within the household, we considered parents to be peers. The survey had no direct information on parents' attitudes on gender roles. We used a proxy measure. We assumed that adolescents were connected to their mother or father if they said that they can always or most of the time discuss about personal matters with them. We also assumed that adolescents who felt connected with their parents had parents with egalitarian attitudes on gender roles. Community peers. We considered community peers for an unmarried girl to be other unmarried girls of the same age group who resided in the same cluster as the respondent. For an unmarried boy, his peers were other boys of same age group and marital status. A respondent was considered to have egalitarian community peers when at least 60% of the boys or girls, as relevant, had egalitarian attitude in the cluster where the respondent lived. Next. Methods used for data analysis. Multivariate linear probability model was implemented to identify the factors shaping attitudes on gender roles after controlling for other variables. Marginal probabilities are estimated for each category of each of the independent variables, and that's what we are presenting in our results. Now we look at the results. First, the influence of contextual factors. Next. The probability of having egalitarian views on gender roles increased with educational attainment. Girls who completed secondary schooling with 34 percentage points more likely to have egalitarian views compared to those with primary complete or less educational attainment. For boys, this difference was 15 percentage points. Next. As expected, boys and girls from wealthier households were more likely to have egalitarian attitudes. Next. Rural girls were less likely to have egalitarian attitude on gender roles compared to those in the urban areas, whereas there was no significant difference in attitudes on gender roles between urban and rural boys. Next. Girls in the western regions of Bangladesh were more likely to have egalitarian views than in the central or eastern regions, but no difference in attitudes of boys by regions was observed. Next. Peer influence. Next. Girls who felt connected to their mothers and fathers were more likely to have egalitarian views. Next. But we see no influence of parents on boys' attitudes on gender norms. Next. Adolescents' attitude on gender roles were highly associated with views of their community peers, more so for boys. Now we look at the influence of social connectivity. Next. Girls who have access to TV are members of social organization and who participated in adolescent programs were more likely to have egalitarian views. For boys, membership of social organization and participation in adolescent program had positive association with egalitarian attitudes. Now, I shall summarize some of the key findings and discuss a few policy implications. We found there is a wide gap in attitudes of girls and boys on gender roles. Girls may tend to be more egalitarian because they're the primary victims of gender discrimination and thus have more to gain from favoring an egalitarian society. Boys hold more social power and may want to maintain their position in social hierarchy. Also, literature review indicates that gender stereotypes tend to be more rigid for men and boys from quite an early age. Thus, program approaches to change gender norms will have to be different for boys and girls. In Bangladesh, programs for adolescents tend to focus more on girls. Egalitarian gender roles will be difficult to implement in the real world when boys' attitudes remain non-egalitarian. Hence, we need to focus changing views of both boys and girls. Another findings. Schooling has significant positive association with egalitarian attitude on gender roles. Now in Bangladesh, educational attainment measured by completed at least some secondary education is higher among girls than boys. Historically, it was not so. Scholarships provided to girls to stay in school have had a substantive impact on raising girls' education. School dropout rates are higher among boys. Over 90% of the boys who dropped out mentioned lack of interest or financial constraint to be the reasons for dropout. We need to rethink how to keep boys in school. We suggest conducting formative research to understand the reasons for dropout and initiatives that can be undertaken to keep boys in school. Next. Community peers' attitude on gender role has a strong influence on individual views, more so for boys. Multi-level interventions are needed to change attitudes. Interventions have to target not only adolescents, but their parents, peers, and broader community members. We suggest the use of existing social institutions, forums, and mass media to promote egalitarian views on gender roles in the community. Next. Participation in adolescent-focused programs is associated with egalitarian attitude both for boys and girls. Programs must include boys and girls. Some of our experiences with adolescent programs in Bangladesh indicate that boys have less interest to participate in these programs. Approaches to attract participation may also have to be different for boys and girls. Review of literature suggests that interventions to promote egalitarian attitude may be more effective if started during early adolescent years. School and other programs on improving gender role attitudes must be able to convince boys that boys will also gain from eliminating gender discrimination. Let me give an example. Boys from quite an early age may feel the pressure that they are considered earners for the family. However, if boys are socialized to understand that all genders should have equal opportunities for education and work outside the home, they may face reduced pressure. We suggest promoting extracurricular activities among girls to showcase that girls are equally capable to succeed in all fields. Mass media can play an important role in highlighting girls' achievements in various fields, as doing so will promote an enabling environment to change community perceptions on gender roles. We recommend rigorous evaluation and well-designed learning agenda to be built in when implementing interventions or approaches to develop egalitarian attitudes so that successful elements can be taken to scale. I conclude by providing the information that our paper was published in the journal Frontiers in Public Health on March 28th of this year. Thank you.
Thank you, Kanta. And also the link to the paper that Kanta's just shared with us, it can be found in the chat as well. Okay, our next presenter is Mr. Moinuddin Haider, MSc and PH, who will present on depression among married adolescent females. Mr. Haider is an associate scientist in the Health Systems and Population Studies Division at the International Center for Diarrheal Disease Research, Bangladesh, known as ICDDRB. He has over 13 years of experience in monitoring and evaluation of population, health, and nutrition programs, and survey and demographic surveillance research. Mr. Haider's other expertise includes health and demographic measurement improvement in population-based surveys. Over to you, Moin.
Thank you, Gabby. We all know depression is a common mental disorder. Globally, it is estimated that 5% of adults suffer from this disorder, which is higher among females. Several biological and social factors have been found to affect depression among women. Many studies have also examined depression during pregnancy and postpartum periods when women go through several physiological, financial, and social changes. In this analysis, we examined the depression across reproductive life course of married adolescent females in Bangladesh. You know, the Patient Health Questionnaire 9 module, in short the PHQ module, is a tool to assess depression. The module asks 9 questions related to severe bad feelings in the last weeks. A composite index based on the responses to the 9 questions is used to assess depression. The PHQ 9 module was one of the important sections of Bangladesh Adolescent Health and Wellbeing Survey 2019-2022. The survey found that the prevalence of depression was 11% among unmarried female adolescents aged 15 to 19. It was 15% among currently married adolescent females of the same age group. Divorced, widowed, and separated females had a depression level as high as 35%. However, the third group is tiny in the population. Among the other groups, married adolescent females goes through critical phases of reproductive life course, including pregnancy and childbearing. These do not commonly appear among unmarried women in Bangladesh. Let us have a brief introduction to the reproductive life course of women. It starts with menarche at around age 12, then goes through childbearing and ends with menopause at around age 50. The childbearing phase goes through critical stages like pregnancy, birth, and postpartum. Marriage is a prerequisite of sexual union and childbearing in many cultures and countries. Thus, marriage is inseparable from reproductive life course in those contexts. Bangladesh is one of those countries where marriage is a prerequisite of sexual union and childbearing. 99% of the population are Muslims or Hindus. Childbearing is not acceptable beyond wedlock in Islam and Hinduism. Religions also influence social norms. On the other hand, the social norm of early marriage and childbearing shortly after marriage affect the independence over the self-choice of childbearing. Moreover, around 1 in 5 of the births are unwanted or mistimed due to multiple reasons. Thus, in Bangladesh, many adolescents experience all the phases of reproductive life course except menopause and may get unwanted pregnancies. From this point onward, we will focus on the context of adolescence, so the menopausal phase will not be discussed. First, what does the reproductive life course of adolescent females look like in Bangladesh? Going to school, spending time with siblings and friends, living with parents, helping the mother with household chores and other works, etc., are common in the life of an unmarried girl. As soon as she gets married, she gets separated from the parents, siblings, and friends, and drops out from school. In addition, she has responsibilities to care for her husband, in-laws, and household chores. Pregnancy and postpartum, that is childbearing and rearing, are common even shortly after marriage for many of them. Sometimes the pregnancy is mistimed or unwanted. No matter what, she goes through physical and emotional conditions of adolescence and childbearing together. Who does not get a child shortly after marriage may go through even tougher conditions. Facing questions like, why no child? What problem? Whose problem is this? Etc. is common. Many may also be afraid of marriage dissolution. All of the happenings in such an age are likely to affect her mental health conditions like depression. However, to our knowledge, no study examined depression across reproductive life course of married adolescent females in Bangladesh. Therefore, in this study, we aim to examine depression across reproductive life course of currently married females ages 15 to 19 in Bangladesh. For this study, we proposed 3 models of reproductive life course. We incorporated time of childbearing and pregnancy wantedness in the models. The first model specifies 4 phases of reproductive life course of a married adolescent female. The 4 phases are: have no child, currently pregnant, had birth in the last 6 months. We define this phase as immediate postpartum, and the last is extended postpartum, who gave birth before 6 months are included in this phase. The second model is an extension of the first model, which divides the no child phase into 2. Married for less than 3 years without any child, and married for 3 years or more without any child. The third model is an extension of the second model and divides each pregnancy and postpartum stage into 2 based on pregnancy wantedness at that time. To examine the burden of depression in different phases of proposed models, we used data from nationally representative Bangladesh Adolescent Health and Wellbeing Survey conducted in 2019-2022. The survey interviewed close to 5,000 currently married adolescent females aged 15 to 19. Among them, a subsample of 2,280 females received the PHQ module, a tool to assess depression. We excluded 128 females from the analysis who had 2 children. The survey did not collect the second child's birth date, thus the postpartum stage was unknown. The only dependent variable is depression in this study. It had whether the girl had depression or not. It was measured based on the PHQ-9 tool that I explained at the beginning. We applied descriptive and multivariable statistical methods to analyze the data. The first model. we found the prevalence of depression was higher among pregnant and immediate postpartum females compared to no child in extended postpartum females. After controlling for a set of socio-demographic, spousal, gender attitude, and abuse-related covariates in a multiple logistic regression model, we find that pregnant and immediate postpartum females had significantly higher depression compared to the females who had no child. We did the same analysis for the second model of reproductive life course. We found that in addition to the pregnant and immediate postpartum females, prevalence of depression was also higher among females married for 3 years or more without any child. We used a logistic regression model with the same covariates to analyze the first reproductive life course model. It showed that the prevalence of depression was higher among females married for 3 years or more, currently pregnant and immediate postpartum women, compared to the females married for less than 3 years without a child. Again, we did the same analysis for the third model of reproductive life course. The prevalence of depression was visibly higher among females married for 3 years without any child, females currently pregnant, who did not want the child at that time, and currently immediate postpartum females who did not want the child at that time. We again applied a logistic regression model with the same covariates used in analyzing the first and second models of reproductive life course. It showed that the prevalence of depression was higher among females married for 3 years or more without a child, currently pregnant females who did not want the child at that moment, and immediate postpartum females who did not want the child at that moment, compared to females married for less than 3 years without a child. Depression was also higher among currently pregnant and immediate postpartum women, but not statistically significant. And there was no statistically significant difference in depression between wanted and mistimed pregnancies and postpartum. The analysis reveals 2 primary sources of variation in depression across reproductive life course of currently married adolescent females in Bangladesh: mistimed pregnancy and having no child after 3 years of marriage. For the mistimed pregnancies, no family planning method use, non-compliance in method use, and method failures are likely to be the primary reasons. However, fear of marriage dissolution and peer or family pressure for a child are likely to affect the mental health conditions for female married adolescents who are married for 3 years and have no child. Rahman et al. Found a higher prevalence of intimate partner physical violence among adolescent females married for 4 years or more without any child. That may be another reason of a higher prevalence of depression among them. However, we think formative studies may help to better understand what happens to them after 3 or more years of married life without a child. The other important finding is that we did not find any difference in depression between females who wanted the pregnancy and who did not want the pregnancy. This finding does not match with existing evidence. Small sample size and first parity might have influenced the finding. Previous studies examining depression by pregnancy wantedness included any order of birth, but this study included only the first order of birth. The further studies are needed to conclude anything on this. I stop here. Thank you all.
Thank you, Moy. Our next and last but not least presenter is Ms. Shusmita Khan, MSc. She will present on factors that provide protection against intimate partner physical violence among married adolescent females in Bangladesh. Ms. Khan is a trained nutritionist who has worked in public health for the last 20 years, focusing on monitoring, evaluation, and learning aspects of health, population, and nutrition programs. Ms. Khan has extensive experience in monitoring evaluation, as well as gender integration in monitoring, evaluation, and learning activities. Currently, she works as the Knowledge Management and Communication Specialist for D4I and is based in Dhaka. And before I pass it over to you, Shusmita, please, if anyone is having, if anyone has any questions, please feel free to write it in the Q&A box. And if you're having any issues with that, feel free to write it in the chat. Over to you, Shusmita.
Thank you, Gabby. Now, we will look at the factors that provides protection against intimate partner physical violence among married females. This was a team effort led by Dr. Mizanur Rahman, and I am presenting on behalf of the whole team. Next. Although the Center of Diseases Control identifies intimate partner violence into 4 broad groups, which are physical violence, stalking, sexual violence, and psychological aggression, for this study, we are only taking the physical violence into account. Next. Unfortunately, physical violence by intimate partner is pervasive across countries around the globe, especially in those with traditional economies. And Bangladesh is no exception, where we have moderate to high level of intimate partner physical violence, IPPV. Such violence has short and long-term negative effects on women's health and well-being with varying degrees and magnitude. For example, morbidity and mortality of under 5 children is significantly higher among women who experience intimate partner physical violence than those women who did not, and major depressive disorder was significantly higher among married adolescents who were IPPV victims compared to those who did not face any IPPV. Next. For this study, we took information from 1,846 currently married females aged 15 to 19 years. And during the interview, they were asked, in the last 12 months, has anyone slapped you, pushed you, or pulled your hair, punched you, thrown something at you, or hit you with a stick or something heavy, kicked you, dragged you, or beat you up, tried to choke you, burn you on purpose with something hot, which could be fire, object, or acid, threatened or attacked you with a knife, gun, or any other weapon. We understand these questions can be triggering for someone and are sincere apologies for that. Anyway, coming back to the study. For the aforementioned 5 categories of questions, if anyone said yes to any of the category, we asked who are the perpetrator. And if anyone answered husband, then we considered those who responded as individuals who faced any form of physical violence from husband, regarded as intimate partner, at least once at the last 12 months. With this operationalization, we found that 16% of currently married females aged 15 to 19 years has faced any form of physical violence from husband at least once in the last 12 months. 16%. That is 1 in every 6 currently married adolescents. To identify factors that provides protection against intimate partner physical violence, or IPPV, among married adolescents, we performed multivariate analysis after controlling for other variables. And the variables were, in case of socioeconomic variables, years of schooling, household wealth quintile, residence, and region of the country. Next. In terms of gender relations, it was attitude towards gender roles and attitude towards gender responsibilities and spousal power dynamics. Next. For understanding spousal demographic characteristics, we looked at husband's age and duration of marriage. In addition, we also looked at spousal connectedness and spousal control. The next 2 variables were household living arrangement, where we looked at if the adolescent lives with the husband and children, if any, or she lived with her husband along with parents or in-laws and children, if any. And lastly, her husband lives elsewhere and she lived with the parents or in-laws and children, if any. The last variable was adolescence, childbearing status. Next. First, let's see if there are any socioeconomic factors that provide protection against IPPV among adolescents in Bangladesh. If you notice that the boxes are colored as deep green, then assume that we have found statistical significance, and in case of ash, there were no statistical difference. As you can see, married adolescents with better education are less likely to face IPPV. from 22% among girls with no or below 6 years of schooling to 17% among girls with 6 to 9 years of schooling to only 7% among those with 10 or more years of schooling. About 20% in the bottom 40% households experienced IPPV compared to the 12% in the upper 40% households, meaning married adolescents from wealthier households are less likely to face IPPV. Next. Let us see if gender-related factors provided any protection against IPPV. As you can see, both the boxes are ash, meaning there were no statistical differences in the difference. And the construction of the first variable was described during Dr. Kanta's presentation. Therefore, I'm not going to reiterate it. And for the second variable, that is attitude towards gender responsibilities and spousal power dynamics, was more on understanding the gender roles within marriage, and the indicator is shown in the right-hand box, the right-hand side box. Next. The third broad category is to look at the spousal factors that may have provided any protection against IPPV. Next. While husband's age and duration of marriage has had some statistical significance, we could not find any significant association in terms of spousal connectedness. Lastly, spousal control was looked by a proxy measure of the girl having her own mobile phone. IPPV risk significantly decreases from 26% among those whose husband was 20 years or old or younger to 17% among those whose husband were 21 to 25 years old, to only 12% among those with husband of 26 years or older. Not having a mobile phone significantly exposes girls IPPV, as it was 19% among those who did not have a phone compared to 13% among those who had a phone. You may have noticed that I have not said anything about the duration of marriage, and that is because we have seen as an interaction of duration of marriage and childbearing status of the adolescent, which I will share at the end. Next. The last broad category is to look at the household factors that may have provided any protection against IPPV among married Bangladeshi adolescents. As you may remember, I shared that we have defined these variables as the girl living with her husband and children as nuclear family, she's living with her husband, parents, parents-in-law, and children as extended family, and lastly, husband lives elsewhere, but she lives with parents, parents-in-law, or she lives alone with the children. And next. And we found that married females living with in-laws and parents are less likely to face any kind of IPPV. As I was saying, that we have seen an interaction between duration of marriage and the childbearing status. And a significant interaction occurs between these two variables. As you can see, there are three distinct effects. First, IPPV risk for girls who did not have a living child increases from 11% during years 0 to 1 to 17% during years 2 to 3 to 29% after 4 or more years of marriage. IPPV risk is higher among those who have a child immediately after marriage, which is 0 to 1 year, and those who have not yet have a children, 18 versus 11%. And lastly, IPPV risk for girls with a child is about similar for the years of marriage duration. Next, in a nutshell, our take-home message is that, unfortunately, intimate partner physical violence among married adolescents is pervasive in Bangladesh. Girls' education is protective of IPPV, as more educated female adolescents have lower risk of IPPV. Married adolescents whose husbands are younger than 21 years are 1.8 times more likely to face physical violence compared to their counterparts. Childbearing immediately after marriage exposes married female adolescent to IPPV. A delay in having a child after 3 years of marriage is also a source for the risk of IPPV. We assume that it is likely because of family or social pressure on the couple to show proof of fecundity. Married female adolescents living in households with presence of parent-in-laws and parents are likely to be more protected from IPPV. And lastly, a phone is likely to be a vehicle that can help receive instrumental social support against IPPV among married female adolescents. Next. In conclusion, we think to prevent physical violence by husband, we ought to keep our girls at schools, as higher education is protective towards IPPV. We must strictly adhere to the law that requires men to marry at 21 or older age so that we can reduce married girls' risk of IPPV. And lastly, in case of early marriage, for whatever reason, for the prevention of IPPV, it is better to live in joint families. Next. The findings of this study were published in the Frontiers of Public Health in April 2023. Feel free to read the paper for in-depth information. I suppose the link is being shared with you in the chat box. And with this, I conclude the presentation session.
Thanks very much, Susmita, and thank you to all the presenters for the presentations today. Next slide, please. So now that the presentations are over, we will move over to the questions period. I've seen there's some questions in the Q&A box, and I think there's a couple maybe in the chat as well. So if you do have any questions, please, there's still time to please write some questions in the Q&A box or the chat. Also, just to bring to your attention that the links have been shared to the paper on what shapes attitudes on gender roles among adolescents in Bangladesh, and then also the paper on the factors that provide protection against intimate partner physical violence among married adolescents. And then we've also provided in the chat links to the full Bangladesh Adolescent Health and Wellbeing Survey report, along with the summary findings and additional information. So with that, I'm going to pass it over to Sean, who will facilitate the Q&A session. Over to you, Sean.
Thank you, Gabby. So as Gabby said, please do continue adding to the questions in the Q&A. Thank you, whoever just added another question. And we have about 15 minutes. So I'm going to start off because there are a few questions that relate to the measurement of depression with the PHQ-9 module. There was one in the, and some of these have been attached in the chat, but since there are several questions, I thought it might be helpful if maybe Cameroon and McMoyne and others could kind of respond. So there was one question that was answered asking about how we decided to use the PHQ-9 question for Bangladesh and the validation of the instrument in that setting. There's also one in the there's also one around who asked the questions that's in the chat, who asked the question of in the PSQ-9 questionnaire of adolescent respondents, were they health professionals or others, and a related question around whether there was a survey considered pregnancy outcomes such as miscarriage as having implications for depression levels. So maybe we could start off with the measurement question. I see, Cameroon, you've answered a little bit here. Would you like to expand on that question a little bit?
Thank you, Sean. We used, in fact, PHQ-9A, which is adapted for adolescent. And to the best of my knowledge, this PHQ-9 has already been used by some other studies in Bangladesh and also in this like South Asian countries, India. So, and we what we did, there is an Indian Bengali version of the PHQ-9 is available in the the PHQ Skinner website. We downloaded that and we pre-tested and also reviewed by the subject matter expert in Bangladesh, and then we use this. That's why we use PHQ-9. Kantappa or anyone else, do you want to add anything?
Who
No.
asked the questions? Could you say that? Oh, sorry, go ahead, Kanta.
The interviewers asked the questions, and the same interviewers who administered all the questions on all the different questionnaires also asked the questions on the mental health module.
Just to add, in the PHQ-9 module, the way it's a self-administered questionnaire, but we used is an interviewer-administered questionnaire, not self-administered. That was the difference.
All right, thank you. And
just to add another thing.
Go ahead.
Sorry, sure. Yeah, for the if you're familiar with the PHQ-A, one of the question is about suicidal ideation. If anybody has any is having any ideation of suicidal tendency, the interviewers or the enumerators were trained in such a way. If anybody answered yes for that question, they were then referred to a mental wellness facility. So we had a referral slip, a number, a hotline number, which was given to the respondent so that they can take immediate support. Just want to add that.
Thank you. Anybody else want to add anything? Yeah. Okay. So maybe for Moin, could you? There's a question here. Did the survey consider pregnancy outcomes such as miscarriage in the analysis of depression levels among postpartum adolescents?
Yeah, that is a good question. The survey only asked about birth, no pregnancy loss like miscarriage, abortion, or stillbirth was not asked. So the data we have solely on live birth. So no miscarriage, no stillbirth, no abortion.
Thank you, Moin. Okay. Okay, there's a question here on, is there a measure of bidirectional IPV that takes into account the research settings, common gender norms? Would the adolescent female's health be affected? So I think Moin, you would like to answer that question.
I would refer Kantappa.
So by bidirectional IPV, I think, do you mean the violence by women on men as well as men on women? We can pop in the chat if you want to add anything, any clarification to the question. But Kenta?
No, we didn't ask. We asked one directional. We didn't ask whether the bidirectional. So we don't have information on that at all.
And has any analysis been done yet on linking violence to mental health, or is that wasn't within the scope of any of these studies? But is that something that anybody is trying to look at?
Yes, I think we are looking.
Yeah.
We are doing some analysis on looking into that. Yeah.
Yeah, we have done some analysis on this, and after controlling for possible socio-demographic and other variables, we find that not only physical violence, but also social bullying and sexual harassments are also associated with the depression. And in fact, the level of depression is the highest when a girl faces any of these abuses, physical violence, sexual harassment, and social bullying. When they face all three forms of abuse, then almost half of them suffer from depression. So this is an ongoing analysis. We hope to publish the results soon.
Thank you, Moin and Kanta. Okay, so we have a question now on the gender attitudes and marriage. How do you explain the western region of Bangladesh having slightly more egalitarian attitudes while early marriage is at the same time higher there? So who would like to take that, Nahid
I
or
will take a
Kanta?
dig at it. We look at that paradox all the time. In Sylhet, we see late age of marriage, and it's much more conservative than the Western side of the country. In the Western sides, women can movement of women is much easier. But so the question is, why is there early marriage in the Western side? It might be community. I mean, some of the hypothesis is that, and that the Western part of the country has been poor, and that could be driving early marriage there, and what the societal norms are. But this has been always a paradox.
Can I add to that?
Sure.
I agree with everything Kantapa has said. So the Western districts bordering with West Bengal of India have always had more favorable demographic indicators, such as age at marriage, as seen in the series of demographic and health surveys. And yes, we do not have a very satisfactory explanation for why this is the case, but one possible hypothesis is that the Western districts behave more like West Bengal due to diffusion, which is why age at marriage and other indicators are much better in the west of the country, despite the fact that those divisions are economically poorer.
All right, thank you. So this next question is for Kanta. In which parts of Bangladesh is the dropout rate for boys relatively higher than that for girls? Why do the boys in these regions feel a heightened sense of responsibility for providing financial support to their families at such an early age?
I looked at the DHS data, and the dropout rates has been higher for boys overall. And I haven't looked at it, whether it varies by region, but many of the boys are also working from a very early age. And if you look at, that's why we were very interested in the reasons why they were dropping out. And the two most important reasons that were quoted one was financial constraint. Another one was they were not interested in what is being taught. So that's why I think this is an area where we really need to look at. If there's financial constraints, then focus interventions on households which feel those financial constraints, because we had provided stipend for girls, but we have never considered stipends for boys. Secondly, they're not interested in the subject matter that is being taught. Maybe they don't see how what is being taught is relevant for their earnings or for their future. So I think those need to be now examined much more, and we have really not focused on those areas at all. We know very little.
We have about 4 minutes left. The next question is that in Bangladesh, the culture admits the marriage in the parents' house. And in conclusion, you say that is the response of care out of violence. I think this is questioning about maybe around a little bit more around the finding that violence was less when people were living in it, when young adolescents were living in their in-laws' household or with parents. I wonder if you could comment a little bit more on that question on the violence.
I will just first take a dig, and then Moin, if he wants to add in, can do that. We are talking about young girls, 15 to 19-year-olds. And it has been a surprise to us at looking at the findings, because we often hear that in an extended household, in-laws and others can instigate, that causes violence. But here we didn't see that. In our culture, the guardians, who are older to us, we kind of respect what they think and their opinions. So our explanation is that we probably find that in an extended household, especially for girls who are young, who are married young, that having elderlies in the house is protective to intimate partner violences. They're probably a bit more careful, so their opinion matters. So this was a bit of surprising finding to us, and we tried to look at whether anybody has done any study in Bangladesh looking at other age groups, but we haven't found any. But it's some area, something we would like to look at further.
Thank you, Kanta. Anyone want to add anything to that? Okay.
Moin does not want to add in anything.
Okay, thank you. Okay, the next question is that the sampling methods of the Bangladesh Adolescent Health and a survey are very complex and have several modules which are not similar to other national surveys like DHS and MIPS. How are those things addressed? I mean, I think Mr. Bila, if you want to add a little bit more in the chat on this, if you have any specific things, but I think we can talk a little bit about that. Does anyone want to take that question? I can also add in if necessary, but does anyone else want to ask that question first?
Can I take it? Dig at it?
Okay.
Yeah.
Okay. Kataba.
Okay. The DHS in Bangladesh, at least, is fully married woman age 15 to 19. So it doesn't have unmarried girls or boys in the sample. Mixed, as far as I know, is also focused towards married women age 15 to 19. The Bangladesh Health Adolescent Survey has to be kind of different because you had to go to 70,000 households and administer a questionnaire just to find out, to get your adults, to get your adolescents population. And so that's the first difference, that you go there. But in DHS, you also go to all the households to find out ever married women. So here, yes, it was a bit complex because we had to also kind of save our resources so that not all unmarried boys were selected, right? But we did select all unmarried girls.
Yes.
In the 70,000 households, all unmarried girls, all married girls were selected for our sample. So in that sense, you know, it's kind of, we didn't leave out anybody.
Yes. Appa.
But we did not administer all the questions to everyone because the sample size requirement did not need all the questionnaires to be administered to everyone. And also, we also know that the quality of data kind of falls when you have a very, very long questionnaire, and we had a lot of modules. So we selected our samples accordingly so that not everybody is asked all the questions. So we had a long and a short questionnaire. So that, you know, we can finish those the survey within a reasonable amount of time, and then we can preserve the quality of our data.
Yeah, if I can add, Sean.
Okay, yes, go ahead, Cameron. Yes, but just try and keep it to a minute because we're about at time.
Yeah, okay. And also there are other complexity. For example, mental health module and their violence module. According to WHO recommendation, violence module cannot be administered more than one person in a household. So that we have to be very selective about this sampling. So yeah, I'm not going to detail it, but you can read in the report. It has all the description of like different modules and which module was administered to whom. Thank you.
Okay, with that, I will hand back to Gabby because we are about at time. And I think we got through all the questions as well. So thank you, everyone.
Yes, thank you so much. Thank you to the presenters. Thank you to all of the participants for joining us today. The recording and the slides, you will receive an email after this webinar. It takes a while for the video recording to get set, but you will be receiving that either later today or tomorrow. So keep a lookout for that. And then again, thank you to the presenters and thank you for hanging in with us for this whole webinar session. With that, I will wish everyone a good night, a good beginning of your day, or a good afternoon. Thank you so much. Bye-bye.